Dr. David Ledgerwood, as you know, is a clinical psychologist and associate professor in the Substance Abuse Research Division at Wayne State University School of Medicine in Detroit, Michigan. He's also the director of the Problem Gambling Clinic at Wayne State. He's the secretary, excuse me, of the Michigan Association on Problem Gambling. And Dave, I will hand it over to you now.
Thank you, Robbie. Great
Sure.
to be here again. Great to see so many people online, and really happy to be talking to you about this particular topic, because this is a topic that I've actually been really interested in for many years. My background, around the time I started in the problem gambling area, I was also doing work in the substance abuse area. And one of the things that I noticed both from clinical work and research work is just the prevalence of trauma and post-traumatic stress disorder among people who had substance use problems. And as I became more versed in doing problem gambling treatment and research, I came to realize that there was just so little research out there on trauma and post-traumatic stress disorder in gambling disorder. And I felt like that was a major oversight in our field. And I'm going to talk a little bit about what's out there in terms of literature and sort of how we can treat problem gambling and PTSD together. But we've come a long way, say, in the last 20 years when I first started doing this work. And I'm glad to see we have, but we still have a long way to go in terms of understanding the extent of trauma and PTSD together.
Hey, Dave.
Yes.
Hey, I'm sorry. A couple of folks, or a few folks, are having a little bit hard time hearing. I'm not sure if it's.
Okay.
Yep.
Let me throw on my my earbuds and see what happens.
No worries. Okay. All right.
Okay. How's that? Is that better?
Yeah. Well, it sounds different. I don't know. Can I get a sound check from somebody? Somebody chat. Let's see. We are automatically muted and video off for this call. No, you guys shouldn't be. You shouldn't be muted.
That's
okay. Yeah. Well, whoever texted me, everybody's saying it sounds good. Thanks, Dave.
Okay.
Whoever
Awesome.
texted me that you're muted,
Perfect.
Or you might want to go back and look. So, but I'll hand it back to you, Dave.
I appreciate it. I try to not use the earbuds if I can avoid it, just because usually the sound's pretty good. But if somebody can't hear, yeah, I definitely want to use these so
okay.
you guys can hear. So one of the sort of questions that I usually ask myself when I'm treating somebody with a gambling problem is it possible that the problem gambling that a person is experiencing is, at least in part, a symptom of some other underlying problem? And when we're talking about trauma and we're talking about post-traumatic stress disorder, my feeling that is that oftentimes it is. Oftentimes gambling is a way to cope with underlying depression, anxiety, nightmares, other things associated with mental health problems like post-traumatic stress disorder. And so I'd like you to sort of keep in mind as we talk about these PTSD and trauma and gambling disorder, just keep a few cases in mind. These three cases are people who I've seen over the years who all had in common some level of trauma or post-traumatic stress disorder. So one was Eliza. Eliza was a 60-year-old retired, widowed African-American woman. Her father had a gambling problem. She had gambled fairly heavily since she was a young woman, but she developed a substantial gambling problem in her young adult, when her young adult daughter was murdered in 1982. And it was quite a horrific murder. Her daughter had a drug problem and got involved with the wrong people and was killed, and her body was found burned in a dumpster in Detroit. And that was traumatic for Eliza in and of itself. But what was more traumatic for her was that the police never got a lead. The police were never able to find out who did this to her daughter. And at the time that I saw her, actually it's an error, she was close to 70 at the time that I saw her. And she hadn't gotten any sort of closure related to the death of her daughter. So a lot of the work that we did together was around post-traumatic stress, depression, complex grief, and how she worked through this. A second case was a gentleman who came to me not because of gambling, only partially because of post-traumatic stress disorder. Jerry was a 59-year-old white Canadian man. At the time that I saw him, he worked full-time as a truck driver for the county. So in the wintertime, he would drive the snowplow, and in the summertime, he would drive a gravel truck or dump truck. He had a long history of 5 years of sobriety from alcohol, and he was quite active in Alcoholics Anonymous. Before I saw him, he had a serious motorcycle accident with a closed head injury, chronic pain, and had multiple surgeries. And what happened to him was he was driving his Honda, one of those big Golden Wing motorcycles, touring motorcycles, down a very straight, very flat country road out in the county outside of Windsor, Ontario. On a sunny day, he was behind a car. The car changed lanes and pulled onto a gravel shoulder near a house. So my client thought that this person was pulling over to park, but what the person in the car actually did was pull onto the gravel and then do a U-turn right in front of my client. My client's motorcycle flipped several times, and he ended up hitting his head. He ended up with a shoulder injury. He ended up with a broken hip and a severe back injury as well. He had a lot of post-accident trauma as well, because he had a lot of very difficult and challenging experiences with medical personnel, including at one point where he was told that he had to have spinal surgery. And he was about to get this spinal surgery when a second opinion found that he in fact had a cracked pelvis. And it wasn't his back that was really the issue. It was this cracked pelvis that needed to be operated on. And he actually felt quite traumatized that he almost had an unnecessary surgery. Well, where does the gambling come in with this guy? I was seeing him in psychotherapy for helping him to deal with the pain, with the post-traumatic issues, with the motorcycle accident and the medical stuff, helping him get back to work. And one of the things he mentioned to me was that he couldn't do most of the things he used to do. So he and his wife were going to the casino a lot more frequently. And over the course of a few months, he started to realize that he and his wife were both spending a lot of money, and more money than they really should have been spending. And me being a problem gambling expert, I happen to say, so do you think this might be a problem for you? And after a session or two of talking about it, he kind of realized, yeah, maybe it is a problem. Maybe I need to back off. And he was able to do that. A third case to consider is the case of Dolores. And at the time that I saw Dolores, she was 50 years old, the single African-American businesswoman who was very entrepreneurial client who had built her own business from scratch. She ran several group homes in the city of Detroit for people who couldn't live on their own. She had a staff working for her. She owned properties. She had had a gambling problem for off and on for several years. But for the most part, her gambling had really gotten out of control in the last 4 or 5 years before I saw her. She had a history of child sexual abuse that resulted in long-standing depression, and the person in her family who abused her was still part of the family, so she had to deal with that aspect of being part of a fairly close-knit family where the sexual abuse had occurred. She also had a early on history of drug addiction. She had a history of use of heroin, cocaine, of alcohol, and she'd been in recovery from those substances for about 20 years. So she'd actually stopped using everything in her 30s. She had some other traumas. She had a child that she put up for adoption when she was quite young, and she knew who was raising the child and would occasionally go and try and sneak a glimpse of the child while growing up. So there was additional trauma there, and her gambling disorder had really sort of taken off in the last 5 years before I started to see her. So we think of those three cases. They're all very different cases, but the one thing they do have underlying them is trauma, and in some cases, post-traumatic stress disorder. So we're gonna sort of jump into this. And for those of you who saw me give a talk a couple of months ago on here on co-occurring disorders, you might recognize a few of the slides in this talk. I tried to remove several of the slides so that I'm not being redundant with you guys, but there were a few where I felt like it would be worthwhile to have a little bit of repetition and continuity with that previous talk. So why would we expect people with gambling disorder to have trauma histories or to have post-traumatic stress disorder? Well, one of the things that we see quite frequently is that oftentimes people with gambling disorder and post-traumatic stress disorder have very similar underlying psychosocial or mental health types of characteristics. They oftentimes use gambling or use something to get away from painful emotional experiences. Sometimes it might be substances, as I mentioned, sometimes it might be the gambling. In other cases, they might experience dissociation or that sense of unrealness being blocked out from being sort of present. And in some cases, it might be other things. So getting involved in activities, being distracted, avoidance, other sorts of things. Depression is very common among both. We know that among problem gamblers, over 50% of problem gamblers experience major depressive disorder. Anxiety is also prevalent in both people with gambling disorder and post-traumatic stress. Dissociation, as I mentioned, and also being impulsive. So impulsive behavior, impulsive thinking, trouble with attention, all of these things are associated with both problem gambling and post-traumatic stress disorder. Now, some of you may remember that some of these data that I'm going to present again or review again very quickly. We know from a very small number of studies that childhood trauma is associated with later gambling disorder later in life. When we're talking about trauma, we're talking about a catastrophic event involving actual or threatened death or injury, or a threat to the physical integrity of a person or to other people, such as sexual violence, so being sexually assaulted, seeing another person sexually assaulted, or knowing of something happening to another person. Indirect exposure includes learning about the violent or accidental death or perpetration of sexual violence to a loved one. So trauma doesn't have to be to oneself, but it could be to oneself, or it could be to another person, another close person. And we see in the case of Eliza, for example, a very stark example of that when she realized that her daughter had been murdered. This graph you may remember from the previous talk. This was a household study done by David Hodgins and his group at University of Calgary, Alberta, Canada. And what he did was he asked 1,372 callers about their gambling symptoms and gambling experience. And he also asked them about childhood maltreatment and neglect. Using the childhood trauma questionnaire, which is something that's actually used quite frequently. And as you can see here on this graph at the very bottom, it's got different types of abuse and neglect. So physical abuse, emotional abuse, sexual abuse, physical neglect, and emotional neglect in a total score. The bars represent the degree to which a person has a gambling problem. So from being a non-gambler on the very far left to being a problem gambler, the black bars on the very far right. And we can see that as a person's gambling disorder symptoms rise, so too do their scores on these abuse and neglect measures. So we see there's a pretty linear and strong correlation between gambling disorder symptoms and abuse and neglect in childhood. This final sort of graph that I presented previously to you as well, just to remind you, is actually by Nancy Petrie and Karen Steinberg. This is a study that they did of problem gamblers who were seeking outpatient treatment. This study was done in the mid-2000s, and one of the papers that they published out of this study was looking at the differences between men and women problem gamblers and their scores on the childhood trauma questionnaire. And as you can see here, women have a tendency to experience more physical neglect. more emotional abuse, and more sexual abuse than do men, male problem gamblers. We see that their scores are a little bit higher on the emotional neglect and the physical abuse scales as well, but they weren't statistically higher than men on those particular scales. A couple of other things I wanted to sort of highlight before we move on to sort of newer material was the use of the ACEs. And the ACEs is a very popular measure of adverse experiences in childhood. And it's actually called the Adverse Childhood Event Scale. And that measures a number of different areas, including emotional abuse, physical abuse, sexual abuse, and emotional and physical neglect, as does the Childhood Trauma Questionnaire. But it also measures things like parental separation, seeing one's mother, parent treated violently or abused, household substance use, household mental illness, so the experience of mental illness in the home, and the experience of someone, parent or someone else being incarcerated while you're a child. And there are a couple of studies that have actually looked at these experiences in the presence of gambling disorder. Lotzen, for example, in a recent study in 2018 in the journal Addictive Behaviors, found that over 78% of past or current people with gambling disorder had experienced at least one of the ACEs, one of the Adverse Childhood Event Scale, and that high ACEs exposure was actually associated with significantly elevated psychopathology over and above the gambling disorder, so more depression, more substance use, more anxiety, and so forth. Poole et al. Did a similar study in 2018. It was published in the Journal of Gambling Studies, and found that experience of childhood adversity on the ACEs was associated with gambling disorder, with the exception of physical abuse. So a physical abuse scale was not actually associated with gambling disorder. This is somewhat inconsistent with what we've been seeing in the Childhood Trauma Questionnaire measures, for example. And a third study that wasn't using the ACEs, but looked at childhood trauma by Roberts and colleagues, also in Addictive Behaviors, found childhood trauma to be associated with gambling disorder among a large sample of men in the UK. So we're seeing across several studies, and a lot of these are either household studies or studies using particular measures, including the ACEs or the Childhood Trauma Questionnaire, that early childhood trauma and traumatic experiences, not just abuse and neglect, but also things like parental separation and other things, are associated with the development of gambling disorders later in life. And this is also something that we have seen with substance abuse literature as well. So I stop here and ask Robbie to jump in with our first poll question. And
Sure.
my aim today is to get to all three. We'll see if that happens.
All right. Well, let me see if I can. Oh, I'm going the wrong way here. Okay. All right. Our first poll question asks, which of the following are not included in the ACEs that was just mentioned by Dr. Ledgerwood? A, is it household substance abuse? Was it B, household mental illness? Was it C, growing up poor? Or was it D, emotional neglect? Which of the following are not included in the ACEs? Household substance abuse, A, B, household mental illness, C, growing up poor, or D, emotional neglect. And we're almost up to 80%.
All right, you guys are going fast.
Wow.
This is terrific.
We might get to 100%.
98%. Wow.
I know.
Wow.
Very good. Awesome. Let's just see if we can get to 2%, T minus 10.
So it's one person. There's one holdout.
There's one person.
All right, you one guy. You got to get in here.
2 seconds. Oh, it went down to 96%.
Wait,
How did that happen?
we got another person who added on to the...
Exactly. Answer the question. All right. Okay.
Okay, I think, there we go. Yeah, okay, almost everyone got it.
Yeah.
Growing up poor is not one of the ACEs, right? Good job. 94% of you got that. Household substance abuse, so a family member having substance abuse problem, family member having mental illness, and emotional neglect are all part of the ACEs. Okay, I should be hitting share results, right? Okay, there we go. All right, so we're going to move on then. So in summary, problem gamblers have higher rates of childhood trauma. Trauma is associated with higher rates of addiction. It's also associated with higher rates of suicide. And we also know that women tend to have higher rates of sexual and emotional trauma than men among problem gamblers. So we're going to move on to post-traumatic stress disorder, and very briefly going to recap um, some data that I showed you last time when we did the co-occurring study, and just picked a couple of slides. But first off, as a reminder of the DSM-5 criteria for post-traumatic stress disorder. As you know, there are several different criteria that have to be met in order to meet a diagnostic criteria of PTSD. It's changed a little bit since DSM-4, but you have to, as far as criteria A goes, be exposed to one or more events that involve the death or threatened death, actual or threatened serious injury, or threatened sexual violation. The person has to have experienced this event, witnessed the event as it occurred to someone else, learned about an event where a close relative or friend experienced an actual or threatened violent accidental death, or experienced a repeated exposure to distressing details of an event, such as a police officer repeatedly hearing details about child sexual abuse. So this is sort of in comparison to the definition of trauma that I already talked about early on. This sort of expands that. You know, we often think of the first sort of three experiences as being the things associated with post-traumatic stress disorder. So experiencing an event, witnessing an event, learning about someone close to dying or being severely injured or in an event. The fourth criteria here, this sort of experience repeated exposure to distressing details of an event, such as a police officer repeatedly hearing details about sexual abuse, is somewhat new, and it sort of goes to, it can be interpreted in a lot of different ways, in terms of like somebody constantly be exposed to hearing about violence towards certain groups, or hearing about or seeing images on the news related to disasters like the 9/11 attacks, or other types of traumatic experiences, or being in or around such a thing when you're sort of viewing it around you. So that sort of expands the definition of trauma to a certain extent. Criterion B involves intrusive symptoms, so unexpected or expected recurring involuntary or intrusive unsettling memories, repeated unsettling dreams, so nightmares, experience of dissociation or flashbacks, or re-experiencing a trauma, strong persistent distress upon exposure to internal or external cues related to a traumatic event, and strong bodily reactions like increased heart rate when a person is reminded of the trauma. So these criteria always remind me of a gentleman who I see who's not a problem gambler, but he has post-traumatic stress disorder secondary to a workplace accident where he was badly injured by an excavator, so a large sort of bulldozer with arm on the back, and he was hit by that, and now every time he sees an excavator or construction equipment, he experiences dissociation, experiences flashbacks, he experiences these intrusive, upsetting memories, and he also has frequent nightmares. So we see this a lot in people with post-traumatic stress disorder. Criterion C involves avoidance, so frequent avoidance of reminders associated with the trauma, avoidance of thoughts, feelings, or physical sensations that bring up memories of the trauma, and avoidance of people, places, conversations, activities, objects, or situations that bring up memories of the trauma. So someone like Dolores, for example, might avoid her family because going to see her family will remind her of the sexual abuse that she experienced. Someone like Eliza will often avoid thinking about her daughter. And in treatment, when I was working with her, what I would do, because it was my belief that she had to sort of experience, understand, and help process some of the grief that she was going through in order to help her to deal with the trauma of losing her daughter so many years later. But what I did was I set it up and said, you know, I think it will be helpful for you to talk about your grief of your daughter's death. But anytime that we bring it up, if it gets to be too much, what I want you to do is just change the subject. And so she got very good at changing the subject when it became too much. And occasionally she would change the subject and say, well, that's all I have to talk about today. And that would be her way of sort of shutting it down and avoiding it. But at the same time, she didn't avoid it through part of the session. So we made some progress in doing that. Criterion D are negative thoughts and moods. You have to have at least 2 of these. So the ability to remember some important aspect of the trauma, persistent elevated negative evaluations about self or others of the world, elevated self-blame or blame for others about the cause of the trauma, negative pervasive emotional states like shame or anger or fear, loss of interest in activities that the person would usually enjoy doing, feeling detached from others, and inability to experience positive feelings like loving feelings or affectionate feelings towards other people. And then finally, criterion E is the arousal criteria. I have to have at least 2 of these. Irritability or aggressive behavior, impulsive or destructive self-behavior. So there's the impulsivity coming into it, feeling constantly on guard or like danger is lurking around every corner. Hypervigilance is something that we see a lot, including among people who are experiencing vigilance in situations that are really even unrelated to the trauma that they experienced. A heightened startle response, trouble concentrating, and insomnia are all criteria that we see quite frequently. So very briefly, I want to talk about, just as a recap of a study that I talked to you guys about a couple months ago. And this was a study actually using the same data as Petrie and Steinberg, where we interviewed problem gamblers who were receiving treatment for gambling disorder. There were 149 of them in 9 treatment centers located throughout the United States and Canada. And we did a number of questionnaires with them. It's not important that you know all of them. They are listed here. And we wanted to look at their rates of post-traumatic stress disorder and factors related to their trauma. And for those of you who saw this talk a couple of weeks ago, you'll remember that over a third of the sample met criteria for post-traumatic stress disorder. In this case, 34% met PTSD criteria. More women than men met criteria, so almost 42% of women compared to 26% of men. And people with post-traumatic stress disorder had higher scores on problem gambling measures as well. So they had higher higher NOD scores. And when we looked at their types of trauma, and this is, I think, what I would like you to take away the most, and I've sort of talked about last time, was we basically divided groups into those who met criteria for post-traumatic stress disorder and those who didn't meet criteria for post-traumatic stress disorder. And not surprisingly, 100% of those who had PTSD had at least one significant trauma that they'd experienced. When we look at the folks who did not have PTSD, which was about 2/3 of the sample, we see almost 84% of the sample had significant trauma in their life. So even though they didn't meet criteria for PTSD, most of them had a trauma, and they were pretty significant traumas. So sexual assault, about a quarter of the sample had a sexual assault in this no PTSD group. Witnessed a serious accident or fire, almost 30%. Were in a serious accident or fire, almost 30%. Have been threatened with physical harm, almost 40%. And so on. You can see down the list. We had very few people who were soldiers in a war. We did have a few of those, but for the most part, it was trauma sort of at home, and sexual assaults, being a serious accident, fire, and so forth. So on to poll question number 2. Robbie?
Yes. Okay. Poll question number 2 asks, true or false? Problem gamblers with PTSD tend to use gambling as a way to cope with negative emotional experiences. Mark A, if that's true. B, if it's false. True or false? Problem gamblers with PTSD tend to use gambling as a way to cope with negative emotional experiences. We got some, boy, answering very
90%.
quickly.
90%.
Yes.
We're there, almost there.
Yep.
Where's our last 5 people? Oh, where's our last 4 people?
Exactly. We're at 92%. We need 4 more.
Come on, guys.
So far, we're looking good.
Oh, we need 3 more.
3 more. 15 seconds. Yeah.
Some people are waiting to the end, see if they can just get it in
Exactly.
earlier. Yeah, 6 seconds. Okay.
Okay, I'll close her down. Okay.
All right.
All
Okay, so let's share the results. That was the most softball question you guys are going to get.
right. Yes.
Okay, so absolutely true. Problem gamblers with PTSD tend to use gambling as a way to cope with negative emotional experiences. Good job.
Good job.
Just very briefly, wanted to present another study that we did. So in the last study, about a third of problem gamblers who were in treatment met criteria for PTSD. We did a follow-up study where we looked at PTSD among problem gamblers recruited from the community. So these were not necessarily people who were in treatment or had ever had treatment for gambling disorder, although some were receiving treatment. So we know that trauma is highly prevalent among problem gamblers. We recruited 150 problem gamblers from the community. Most of them had gambling disorder. A few of them had sort of sub-threshold problem gambling. What was different about this study is we recruited exactly half men and half women, whereas the previous study was majority were men. We were recruiting them from the community and from college sample, and about 16% had ever received any sort of gambling treatment. But what was really quite interesting was the majority of them had received mental health treatment at some point in time. On average, they were in their mid-30s and started gambling around age 19 years old. And here's what we found in this group. So again, you might expect this group to be a little bit more healthy than problem gamblers recruited from treatment sources, but we found that almost 20% of the problem gamblers in this particular study met diagnostic criteria for post-traumatic stress disorder. So a third in the previous study, treatment seekers, 20% in this study of non-treatment seekers. And when we looked at other co-occurring mental health related issues, we found there were certain things that were associated with post-traumatic stress disorder, including lifetime history of a substance use disorder, lifetime history of depression, current depression, anxiety disorders, as well as current and lifetime histories of anxiety disorders other than post-traumatic stress disorder. So we're seeing PTSD is associated with a lot of other co-occurring problems. And we also found that when we looked at motivation or reason for gambling among problem gamblers with and without PTSD, we asked them if about their social social motivations for gambling, so being around people, their excitement or enhancement needs around gambling, and their use of gambling as a way to cope with things. And the only difference we found here was that those with PTSD were significantly more likely to use gambling as a way to cope with emotional experiences. So they don't seem to use it more for excitement or for social outlets. It's really about the coping. So trauma and PTSD issues are prevalent among problem gamblers. They're associated with higher rates of substance abuse, with depression, with anxiety disorders. And a lot of individuals use gambling as a way to cope with painful affect related to trauma. There were a few other studies that are out there. Like I said, there aren't that many. There are a couple done by Josh Grubbs and his group. In one study, he found that just about 43% rate of post-traumatic stress disorder among problem gamblers who are veterans seeking residential treatment for gambling disorder. So this number to me seems a little bit low. I would expect among problem gamblers seeking residential treatment who are also veterans that PTSD might be sort of a larger factor. Josh Grubbs and his colleagues again published another study in 2019. They found that PTSD among people with gambling disorder who are also veterans and mostly recreational gambling adults was associated with significantly higher endorsement of gambling-related cognitive distortions. So people with gambling disorder among the veterans were significantly more likely to have distorted thinking around things like illusion of control or ability to sort of affect the games that they're playing and to win, when in fact they don't. Maniaci and colleagues found PTSD to be a significant predictor of gambling disorder treatment dropout among people with personality disorders along with personality disorders and substance use disorders. So people with PTSD are more likely to drop out of treatment. And that's also been true of other forms of mental health problems, depression, impulsivity, and so forth. Those things tend to make it more likely that a person's going to actually drop out of treatment. So from a treatment standpoint, it's important to address both the post-traumatic stress disorder and the gambling disorder. Oops. All right. So there are other clinical implications. Trauma may be a precipitant of the gambling problems. And in many problem gamblers. And in fact, in the last study that we did with Alex Milosevic, where we looked at the rates of problem gambling and PTSD in the community, what we found was unexpected. We were expecting that the vast majority of people with gambling problems and PTSD would have experienced a trauma first and post-traumatic stress disorder, and then gone on to experience gambling problems. But what we in fact found was the rate was roughly 50-50 among the group of problem gamblers with PTSD. About half of them reported experiencing trauma first, and half of them reported developing gambling disorders first. It was very unexpected. And one of the things that I think might be happening is it's possible that some of these problem gamblers may have experienced other traumas even earlier in life that they weren't really attributing to the post-traumatic stress disorder. So maybe childhood trauma that didn't result in PTSD, but they had experienced other traumas prior to the incident that they believe caused post-traumatic stress. We know that a primary motivation for gambling among people with gambling disorder with post-traumatic stress may be escape from painful emotional experience. And that's not only true for those with PTSD, it's also true for people with depression, anxiety disorders, people going through negative life events, and so forth. We know that gambling in and of itself is a distraction for these folks. It helps them sort of get away from things. So gambling may be a way to cope, maybe associated with more distorted thinking around gambling. And clients presenting for problem gambling treatment should be assessed for post-traumatic stress disorder and exposure to major psychological trauma, especially because the vast majority of your clients are likely to be experiencing trauma. So some of the things that we don't know, or that we really should be asking ourselves as researchers and as clinicians, does problem gambling increase the likelihood of becoming traumatized or victimized? Does gambling serve as a coping tool for gamblers with PTSD, or does PTSD place the individual at greater risk of problem gambling? And are our current treatments appropriate for treating problem gamblers who are experiencing symptoms that might be also related to trauma, and might be related to post-traumatic stress disorder? And unfortunately, this last question is a difficult one. Before I get to it, I'm going to have Robbie do poll 3 for us. And
Yes.
this is the first time I made it to poll question number 3.
All right.
And we still have almost 20 minutes.
We're good. We're good. Yes. We moved right through it. Let me, okay, stop share results. Oh, okay. Here we are. Okay. So poll question number 3 asks, after I launch it here, how many individuals with gambling disorder have PTSD? Is it A, 20 to 35%? Is it B, 87%? Is it C, 100%? Or is it D, 2 to 3%? How many individuals with gambling disorder actually have PTSD? Is it A, 20 to 35%? Is it B, 87%? Is it C, 100%? Is it D, 2 to 3%?
This one I made a little bit harder. You do have to sort of.
No, it's all right. All yours are really, I mean, the last ones, mine are very, very easy. I put together. So this one's a little bit, in fact, I'm trying to remember on this one. So we've got 79%, 80. Yep.
Okay, I'm getting there.
Yep.
Okay, you got 8 seconds.
T-5, 90%. Can we get up to
92?
Yeah. Good job, guys. Okay. Let's go
Okay.
ahead and end the poll and share the results here.
All right. So most of you got it. 64% of you got it right. You remember in my study with Nancy Petrie looking at Those who were in treatment, we had about 34.6 or 7 of our participants met criteria for PTSD among those who were in outpatient treatment. And in the other study with Alex Milosevic, my student, we did the community-based study and found about 20% met criteria for PTSD. So I gave a range of 20 to 35%. That's about right for what we typically see in people who are receiving treatment. Now you'll remember that Josh Grubbs, one of the last things that I mentioned, that in his study found, I think 42 or 47%, I think it was 42% of his participants in his study who are receiving residential treatment in VA setting criteria for PTSD. So that's a little bit higher, but they're a specialized group. The 87% threw people off. So a third of you said 87%. And that was because 87% was in the first study, the percentage of people with gambling disorder who had significant trauma but did not meet PTSD. So there's where the 87% came in there. So that was a little bit tricky on my part. So I kind of fooled you there. All right, so we'll get rid of that. And we're now talking a little bit about treatment. And this will be a short section because there's very little out there on treatment. So how has trauma or post-traumatic stress disorder been addressed among problem gamblers? Well, in a variety of ways, through supportive counseling, through cognitive behavior therapy, exposure types of approaches, including EMDR, and through other sort of specialized approaches like Lisa Nadjevitz's seeking safety approach, which is a form of cognitive behavior therapy that has been developed for co-occurring substance use and trauma, PTSD, and has been adapted to gambling disorder. There's not a lot of evidence out there for the efficacy of any of these, and to date, there are only a couple of published small studies that actually look at the treatment of co-occurring post-traumatic stress disorder and gambling disorder using psychotherapy types of approaches. And as a matter of fact, there are only 2 studies, one focused on seeking safety and one focused on EMDR. The first one was a very small pilot study that was done by Lisa Nadjevitz, and this was a few years back. I am actually really excited that I'm working with Lisa Nadjevitz on a second study on seeking safety, and we are almost finished with our study recruitment. So our next step will be writing up the results. But the basic tenets of seeking safety, the basic features are safety as an overarching goal, so helping clients to attain safety in their relationships, their thinking, their behavior, their emotions. It's an integrated treatment, so working on both the gambling and the post-traumatic stress disorder at the same time. It's a focus on ideals to counteract the loss of ideals that occurs in both addiction and PTSD. So it's a focus on what are your values, what is important to you, how can you live your life in that way, how can you reduce the fear in your life, reduce the destructiveness in your life, and so forth. There are 4 sort of content areas, so cognitive or thinking, so it's looking at sort of distorted thinking and focusing on new ways of thinking. Behavioral, so changing behavioral patterns. Interpersonal, so how do you relate to other people, and sort of a case management component. And it has attention also to the clinician and the clinician's processes, so helping clinicians to work on countertransference and self-care and other issues, because clinicians who work with people who are experiencing trauma all the time are constantly being sort of told about all of these horrific and traumatic things that have happened to their clients, and that can actually have a pretty big effect in terms of burnout, in terms of vicarious traumatization with the providers. So keeping your clinician healthy and keeping your clinician sort of taking care of themselves and coping well is important to the health of the client as well. There's only been one very small pilot study looking at seeking safety, very small, 7 people, and they followed people from the beginning of treatment to the end of treatment, essentially, and they found that that participants in the study actually generally did quite well. So focus was on positive change in both the gambling and the PTSD symptoms, and both of these things improved. So there was less gambling, the PTSD symptoms improved as well. But what's important to know, it's a very small study, very small pilot. It's not a clinical trial, and we have a need for clinical trials. And what we're doing currently is a clinical trial where we randomly assign people to one of two treatment conditions. And we're hopeful that that will also show us some good results. There's been one study that has used EMDR, eye movement desensitization reprocessing, for gambling. It's an older study. It's 1996. And of, I'm sorry, I'm going to move this for a second. And of course, it was originally designed to alleviate the stress associated with traumatic memories. Based on Shapiro's adaptive information processing model, EMDR facilitates the accessing and processing of traumatic memories and other aversive life experiences to bring these to an adaptive resolution. After EMDR, affective distress is relieved, negative beliefs are reformulated, and physiological arousal is reduced. So there's quite a bit of symptom reduction after EMDR sessions. During EMDR, the client attends to emotionally disturbing thoughts and sensations and materials other than that in brief sequential doses while simultaneously focusing on an external stimulus. So oftentimes it'd be like the eye movement. So focusing on that while also attending to these thoughts. The therapist directs lateral eye movements that are most commonly used in external stimulus, but a variety of other stimulus, including hand tapping, and audio stimulation is also used. So a main hypothesis by Shapiro is that EMDR therapy facilitates accessing of the traumatic memory network so that information processing is enhanced with new associations forged between the traumatic memory and more adaptive memories and information. So it helps people to sort of sort things out essentially and be able to sort of more adaptively incorporate those traumatic memories into their broader sort of sense of schema and sort of sense of how memories are actually structured. And the study that was done by Henry in 1996 involved 22 individuals who met DSM-4 criteria for pathological gambling. It also had post-traumatic stress disorder, and it compared the effect on gambling event frequency of EMDR therapy with cognitive therapy to that of cognitive therapy alone. So the EMDR was basically an add-on therapy to cognitive therapy. And they looked at pre and post EMDR, and they found that that it was actually useful for both the gambling and the trauma experiences. So both improved with EMDR and improved more than with the cognitive therapy alone. So to date, there have been no additional treatments for co-occurring trauma and gambling disorder. But as I mentioned to you, we have a study going on right now that we're hoping will end very soon. We're just trying to get our last 10 or so clients for the study. And it's a telehealth-based study, so it's computer-based or telephone-based. And we're actually working with people who have co-occurring trauma and gambling disorder who live in Ontario or Manitoba in Canada. So if you know anybody out there who would like to participate in the study, that would be great. You'd let me know. So just a recap, just sort of coming to the end of this, back to our cases. Eliza, how I resolved with her, she actually did a really great job sort of addressing some of the grief and the trauma around her daughter. And when we ended treatment, she'd stopped gambling altogether. And she had felt like she had gotten to a point where she was coping with the grief and with the post-traumatic stress a little bit better. Now, our treatment was focused on the gambling disorder primarily, and as is true in a lot of places, we don't often have enough sessions to really help people address everything around post-traumatic stress. A couple of other things were happening with Eliza. She also started to have some memory loss. She was older, as I mentioned. She was about 7 years old. She also had lupus, so she actually, once she ended treatment, her main focus was a little bit more on the side of trying to take care of her physical health. But when I've been in contact with her since then, she's not gone back to gambling, and she was doing better in terms of the trauma experience. Jerry stopped gambling. He ended up retiring, and he was actually physically in much better shape when he left treatment. Psychologically, he still had a lot of anger towards healthcare professionals and towards the person who hit him on his motorcycle, but he was still sober. He wasn't drinking, still involved in AA. And like I said, he'd stopped gambling. And finally, Dolores had several periods of time of stopping gambling. She actually had some prolonged recoveries from gambling that lasted several months to a year. But ultimately, she sort of disappeared, and I never had closure with her. And unfortunately, I'm not sure that she stayed in the state of Michigan or if she went back to New York, which is where her family was. And she didn't come back into the system, as far as I know, in terms of gambling treatment. I don't know if she was able to stop gambling. I also know that she had a lot of financial stressors, including problems with the IRS and other potential problems related to her business. When her gambling was at its worst, she would spend her bank card into the red by up to $1,000 because her bank would allow her to do that. And in a couple of cases, she actually spent the payroll money that was meant for her employees. So she got herself into a lot of trouble and unfortunately disappeared in terms of treatment. And I wasn't able to get back in touch with her. So I'm not sure how she ended up resolving her gambling. But we have a few minutes at the end. I think this is a bit of a, actually timed this one a bit better than the last couple of talks. And I don't know, we could have a couple of minutes of discussion if you want, or any questions, or we could revert back to our discussions of people going into the casinos now in Vegas and other places, or whatever you want to do.
Yeah, and Dave, we do have a question from Nina, who had a question earlier about
Okay.
PTSD and some research actually. Have you looked into or know of any research using alpha stem for PTSD in gambling clients?
I do not. No.
Okay.
No, I'd be really
Okay.
interested to hear more about that.
Yeah.
Mm.
Good question. And let me check the Q&A. Yeah, I don't think we have anything from Q&A, but I really liked how you looped back. Oh, yeah, we do. We got a couple here. Hold on. Oh, nope. Can you put the, okay, yeah. If you guys want the slides to this, go, you can contact me actually. Go to weknowthefeeling.org, weknowthefeeling.org. And if you go to the For Providers tab, my name, number, and email address is there. Just email me and I'll get you the slides. So, but we've got some other questions here. That's weknowthefeeling.org, For Providers tab. Center bottom is my email address. Let's see here. I have many calls for, but poor follow through. Is that something you have found as usual from Mary? Hey, Mary. So Mary's asking, as far as it sounds like, and Mary, you're asking when gambling disorder, problem gambling is comorbid with PTSD, are you having issues? She's having, it looks like,
Poor
oh,
follow through in terms of people showing up for their appointments, or?
yeah, I would imagine. She says just for all gambling clients. Yes.
Yeah, no, that's always been a tough one. I've done some work with the Michigan helpline, for example, and we've done some research where we followed people through time. We did one study and looked at, for example, reasons why people don't follow through after they call a helpline with when they get a referral for treatment, why they don't go and make that first appointment with the therapist. And ultimately what it sort of mainly came down to is people kind of know that when they first call the helpline. They know, like, if we ask them what is the likelihood that you're going to follow through and make this follow through this referral to this clinician, people who don't follow through eventually follow through at that first call they are less likely to say they would. They have like a lower score. It's also true that those folks tend to not feel like they have as big of a problem or feel like they want to deal with the problem on their own. So the motivation is a huge factor there for sure.
Yep. And I've got a question from Maria. She's asking about actually sex addiction,
Mhm.
comorbidity with gambling. What is the first treatment if she's asking? I don't know if she's asking perhaps of which does
Mhm.
she treat first, or is there, if there's a primary
Oh yeah,
you
yeah.
know,
That's
I
I
bet
think
you,
you can
yeah.
treat them co-occurring in a co-occurring way. I don't have good data on what's the co-occurrence of sexual addiction or hypersexuality or compulsive sexual behavior, whatever you want to call it, and gambling itself. I actually just put together a really cool talk for a Michigan group that just highlights different types of behavioral addictions in addition to gambling disorder, and compulsive sexual behavior was one of them. And it is not actually in the DSM at all, in the DSM-5. There was a big push previously to have hypersexuality included in DSM-5, but it didn't get in. Um,
Yeah.
so there's not necessarily great data out there on co-occurrence between gambling and other behavioral addictions.
Yeah.
But I think if you're going to treat it, they're both very destructive behaviors, right? Like
Yeah.
in terms of depending on what the compulsive sexual behavior is, like if it's going out and having anonymous sex with strangers or hiring prostitutes or that sort of thing,
Yeah.
that's pretty destructive. Um, Gambling too is very destructive. You're spending a lot of money. It's hard to choose one of the over the other sometimes. um, in some cases you might want to I would say you want to treat them both. We do know from a substance abuse standpoint that sometimes if you're treating drug abuse with other things, including things like quitting smoking, you get better outcomes. If people are able to quit smoking while they quit drug use, they're more likely to stay quit. So if you
Okay.
could
Wow.
get people to quit gambling while they quit, whatever the compulsive sexual behavior is, you might be able to get them to stop altogether. And for some people, the two might be wrapped up together, right?
Yeah, yeah, right. Yeah, right. Because I working with people who are addicted to substances that's comorbid with other maybe even
Mhm.
behaviors. It's kind of like an all or nothing thing. I've
Yeah.
learned, and they can be
Mhm.
connected. I don't. Yeah. So, but great. Yeah. Hey, and guys, it's a couple minutes past the hour. We want to thank everybody. If you've got to go, we understand. If you've got question for, I mean, time. Sorry, Dave. For
Mhm.
one more
Oh
question.
yeah,
Well, this
absolutely.
yeah, now, and Ellen had a great question here about, and by the way, guys, thank you. I'm going to check with the webinar folks or the website folks to make sure that community outreach webinar is on there so you can sign up.
Mhm.
So I just got a question about that. But Ellen also asked about eating addiction as well. I mean,
Yeah.
and that's a good question. I mean, do you have any experience with folks have comorbid either anorexia or
Mhm.
bulimia, um,
I
with the problem
I
gambling.
don't not
Yep.
not in those two groups, but those feeding types of disorders like anorexia and bulimia are not usually what we're talking about in terms of eating related disorders that are associated with addictions, behavioral addictions.
Yeah.
What we're usually talking about is what we call food addiction, which is basically an addiction to certain types of food, like high calorie, high fat, high salt, high sugar
Ah.
types of foods.
Yeah.
And it's not the same as binge eating disorder.
Okay.
It's
Oh.
different, right? So someone can have binge eating disorder while they have a food addiction, but those two are, if you look at them, how they're categorized, they overlap substantially,
Uh huh.
but they're in different categories of types of disorders. So if you really look at the binge eating disorder, the anorexia and bulimia, and you look at how they're categorized in the DSM, they really don't fit with the addictions. But others have proposed um, uh, eating addiction and food addiction as terms, and there's a debate in the literature about what's a better term, eating addiction or food addiction.
Uh huh.
Eating addiction is probably not the best term because it's about it is about the behavior.
Mm-hmm.
It's about eating, but it doesn't sort of recognize that there are certain types of things that you're more likely to be addicted to eating, right? Like I
Right.
said, the high fat, high calorie, high salt, high sugar types of foods. So there's a lean towards calling it food addiction because it's the types of food. That has implications for whether we consider this in some ways a behavioral addiction, because eating is a behavior,
Uh-huh.
or substance addiction because
I
food is a
see. Yeah,
substance.
yeah, yeah. Okay.
So there's, and I forget what the original question was, so I went
No,
on a
well,
tangent.
if you've worked with, it was Ellen, and Ellen
Yeah, I
commented on
haven't
what it, yeah, I think
really.
it's interesting. Yeah, and I didn't know that.
Yeah.
But it makes sense what you just said as far as how
Mhm.
you're dissecting. It sounds like to me some of the root causes
Right.
of
Mhm.
the symptoms itself of the disorder. Eating disorder is one I have and I experience, and frankly, I just that's
Yeah.
wouldn't be and not not
Well,
my thing, but very complicated, right?
I just created a really cool talk on like 4 or 5 different behavioral addictions. If you ever want me to do that webinar, that'd be
Yeah,
fun too. Yeah.
that might be a side deal for me,
Side
Dave.
deal,
I
yeah.
might, yeah. Over
But no,
dinner at a
I
conference,
over dinner at a conference,
exactly.
we'll just
I'll
break out the
pay.
PowerPoint.
Exactly. Yeah. No, very interesting.
No,
Yeah.
but
Yeah.
I think
So
I have not actually seen that. I've seen a lot of other things. I've seen the compulsive sexual behavior. I've seen the compulsive shopping
yeah.
a lot of compulsive shopping. Um, those are the main things. Compulsive gaming, internet use, and also compulsive pornography use, which fits under compulsive sexual behavior as well.
Yeah.
Hmm.
I know this is for another discussion, but I've seen just like how, the medication used for Parkinson's and
Right.
restless leg syndrome, that
Hmm.
activates all the addictions that include gambling addiction. So would there be some biology connected to that, you
Yes.
think?
Yeah.
Okay.
Absolutely.
Okay.
Yeah. Hmm.
Wow.
Yeah. As
That's,
a matter
yeah.
of fact, I mean, I think I don't know if I did this for the Illinois group, but the gambling in the brain talk recently, that might have been North Carolina, but where we talked a
Yeah.
little bit about the dopamine receptor availability among people with Parkinson's who are on like a dopamine agonist, who ended up developing gambling problems. That's also true with other types of compulsive behaviors,
Yeah.
like compulsive shopping and sexual behaviors and so forth. That can happen as well.
Yeah. You
Mhm.
know what? They're running together, and I'm trying to check my two lists here because I've got both states and I can't
But
find it.
trust me,
But
I'm getting confused now too.
it's all right. Yeah. It's a good thing we're busy, as we were saying earlier.
Yes.
But
Yeah.
Dave, hey, I appreciate. I really like how you wrap back around to those
Good.
cases because I was wondering. I said, "Well, what happened to the three?" But
Yeah.
honestly, I kind of knew because I'd heard some of this talk at a conference before you did, which was great.
Mhm.
I'd forgotten, so I was going. So I appreciate you wrapping back around and connecting the dots. That was a great talk, and we want to thank everybody that's been on. And
Yeah.
again, our next webinar will be June 23rd, Cognitive Distortions in Gambling. I'm glad I'm making that announcement. Dave, get ready because you're going to get my usual email about CEUs.
That's right.
So,
And
okay,
poll
good.
questions.
Yeah, all that's coming, man. Yeah. So,
All
but
right.
I hope everybody continues to stay healthy and
Yes,
safe out
everybody.
there. Okay.
Yeah, thank you so much, everybody.
Okay. All
Really,
right.
really appreciate being able to come and talk to you.
Cool. Thanks again, Dave. Thanks, everybody.
Hey, Robbie.
See you. All right.
Bye.